All right. Hello, everybody. Welcome to Coach's Corner. This is a webinar that we have started to try to bring together the sports community in Indiana. We've been really thankful to partner with IHSAA to make this a more statewide opportunity. The webinar is hosted by myself. I'm a knee and shoulder surgeon in Bloomington, Indiana. And I hope together that we can just pass along good information and learn from each other to educate everybody involved in these athletes' care to provide happier, healthier athletes. Previous topics we've covered included concussion care and lower extremity stress fractures. Upcoming topics will include strength and conditioning with my good friend Will Fleming in January. And in February, we're going to cover sports nutrition. And our guest is going to be Isaac Hicks, who heads up the Indiana University Sports Nutrition Department. Today, we're going to cover functional movement screens with two of the very best, Scott Hamersly and Sara Myers. Sara has worked with DePauw and Butler Universities. She's worked with Forté in some capacity since 2002, including outreach, athletic training to schools, physician clinical assistant work, and now works as a triage athletic trainer within our therapy department, where her various experience has certainly helped to elevate patient care there. Scott Hamersly is a physical therapist and athletic trainer with us for the past 28 years, where he currently holds the position of Director of Rehabilitation Services. He graduated from Old Dominion in '91 with a master's degree in physical therapy. Prior to that, he was at IU. He's a board certified specialist in sports physical therapy, as well as an athletic trainer, and he's a certified strength and conditioning specialist as well. When you look at his letters behind the name, there's way too many: MS, PT, SCS, ATC, CS, CS, BLT, KFC, you name it. It's back there. So we're happy to have them with us and just have a discussion about functional movement screens and how that might apply to our athletes. Quick reminder, if you've got a question, please use the chat function. I'll be monitoring that throughout our session. And then also a reminder, I would love for you guys to fill out evaluations on these webinars to give us some feedback, as well as to provide great topics for the future so we can make this something that is beneficial for everybody. So without further ado, Scott and Sara.
Great. Thank you, Dr. Linger. Yeah, today's topic, functional movement screens. I'm assuming there's a wide variety of people logged in that have a wide variety of exposure to this. You may have heard of the FMS, you may have heard of movement screens, or this may be something completely new to you. This is something that's been around for a while, and as most cases, it really kind of exploded on the scene once the NFL tapped into it. And so with our affiliation with Indianapolis Colts, that became a big thing for us in the early 2000s. And so it's become an integral part of our practice for our trainers out at the schools, as well as our rehab department and the patients that we treat. So my goal today is to give you a little background of what this is and how it came about. The history of this, the original goal was try to find some type of way to objectify human movement. We've all seen athletes that move and are like, wow, they're knock-kneed, or they're not smooth, or something like that. We're trying to define what is normal, all right, in the eye of the beholder. So this led to the creation of some type of standard operating procedure, some SOP for movement pattern appraisal in both just the general population in fitness as well as in rehabilitation. So most orthopedists, therapists, people in the healthcare community, biomechanists, they use kind of a reduction type of thinking mechanism, meaning you're assuming that by measuring isolated parts, I look at someone's elbow flexion or how well they can rotate their neck or how strong their quadricep muscle is, that I can then interpret and predict how well that person's going to do. And that's quite honestly, for many decades, how healthcare works. Someone had a knee injury, we wanted to work on their quad strength. We would measure quad strength and it's back to normal. So therefore, they're going to be well playing fullback on the football team. Well, that's not necessarily the case, because we all know sometimes whole movements can be greater or lesser than the sum of its parts. So the key is, do you want to look at the tire, the chairs, or the muffler, or do you want to look at the car when it's all put together and see how well of a vehicle it is? And that's kind of what we're trying to do with a movement pattern applied to the human body. Our brain processes multiple signals, all right? Movements into a pattern to become efficient, right? And efficient movement does two things. It enhances your performance, whether you're just trying to get out of bed in the morning and walk down the hallway and get a cup of coffee, or whether you're trying to, jump and dunk a basketball, right? It also reduces the risk of injury, and especially micro traumatic injuries, overuse injuries, repetitive traumas, that type of thing, which is on a massive upswing over the last decade. I'm sure people have seen that in the news when it comes to our adolescent population. The history for this, most testing formats, again, measure physical fitness. How much can you lift? How well can you reach? That kind of thing. Or athletic performance. What's your T-test timer? Can you dunk a basketball? Or what's your, miles per hour on your tennis serve, right? So those are the things that tell us what you do, but you really need fundamentals to be able to accomplish that. Back to the efficient movement part of things. So again, it's very similar to coaching in general. You got to have the fundamentals first before you apply anything else. So we put that into a systematic testing procedure. So the FMS is a tool that combines all that, and it adds to this current testing, right? We still want to look at vertical jump, or how much someone can bench press or deadlift, or what their mile per hour on their pitch is, or whatever. But this adds it. It's not replacing it. It's just another tool in the tool belt. So again, you got to have the basic fundamental movement patterns before you can successfully perform an athletic or even a work-related task. We use this in the lay population for workers' comp patients and that type of thing as well. Here's our good old-fashioned food pyramid that we put together. So you got to be able to move. You got to have the fundamentals. That's movement. Before you can apply that and move efficiently and have power, before you can put that into some type of skill. Again, whether it's doing a backflip, shooting a free throw, any of that kind of stuff. Right? Movement. Again, kind of restating what I just said, you must possess normal, efficient movement patterns prior to training, performance, or skill. If not, this is going to lead to impairments in performance and possibly microtraumatic injuries. So you can practice, but if you don't have the fundamentals, you're just practicing to enhance a altered, faulty movement pattern that's going to be ingrained even deeper, and it's going to be harder to correct later on. Think of coaching a golf swing. Someone can go out there and they can swing the golf club, but they got some hitch and they keep slicing, but they keep practicing. They're going to be the world's best slicer, right? Unless you correct it and get the fundamentals to begin with to be able to hit it straight. So the FMS helps fill that void between pre-participation medical exams and performance enhancement or skill development. Think of this: if we do it, everyone goes through every year in high school, goes through a pre-participation exam. We say they're medically safe to go play sports, right? So then the golf coach or the basketball coach or the wrestling coach gets a hold of them, and I'm going to teach them to be a great wrestler. But there's an in-between part, like they're medically cleared to do something, but do they have the back to the foundation of the fundamentals to be able to apply that to what they need to do? All right. Again, first move well, then move off often. That's kind of the guy who came up with this, Gray Cook, a physical therapist, who really didn't come from an orthopedic background. He came from a neurodevelopmental background and has applied that into the orthopedic world. He's the one who coined that phrase, and we use that quite often when we're dealing with our athletes. The functional movement screen, again, the standard operating procedure that was developed, they needed something that was doable. It's a screen, something that can be done efficiently and quickly by a personal trainer, by an athletic trainer, by the assistant coach, by someone at a YMCA to kind of quickly move through some patterns. And so they came up with 7 core movements. And that's what we're going to get into today. That's what Sarah's going to talk about. We talk about the squat, the hurdle step, the inline lunge. We look at shoulder mobility, an active straight leg raise, a push-up, and a trunk stability. Those are the 7 tests in that sequence of order that we go through. And there's a reason we do that. And we'll get into that today as well. So it's a combination of these 7 tests involve basically the full range of motion of all your major joints. It's looking at your ankles, your knees, your hips, your spine, your shoulders, your neck. All that is captured in all 7 of those tests. It looks at adequate flexibility and or length of major muscle prime movers, your quads, your hamstrings, your abdominal muscles, your rotator cuff muscles. All those things are caught in bits and pieces of all these tests. And then it puts it all together. Can you move? And do you have the mobility of the joints and the muscles? But can you also control that movement? The stabilizing control of important core muscles. And quite honestly, that's probably what I spent 90% of my time working on as a therapist in a clinic, working with athletes, not just the 14-year-old freshman who's grown 6 inches over the summer, but also the $6 million defensive back with the Indianapolis Colts, who's made it through all those levels and still is missing some core fundamental stuff. We see that a lot. We see a lot of guys that have brilliant college careers, and then they're just riddled with injuries their first year or two in pros when they jump to that highest level and they realize they really didn't have the foundation that they thought they had that was missed along the way. So that's what we're trying to capture and prevent early on. So this screen, those 7 tests I alluded to, it identifies a normal standard of what we want to see to be able to perform athletic endeavors. It rates and ranks deficiencies. All right, what's off kilter and what needs to be addressed. It uses the combination of information acquired from all 7 patterns. So just doing one test isn't going to do it. We need to do all 7 of them. It's not really diagnostic. I can't do a test and say, oh, this guy's got an ankle sprain, but it leads me down the road to start thinking there's something going on with this movement, and I think it's coming from his ankle. So that's what we're going to address, right? The goal with it when they developed this 20 years ago was to try to come up with a predictive system to address that, to say, look, if someone doesn't score well, they're at a certain percentage chance of risk of injury. We've never really gotten that point. I don't know if that's even realistic. I don't even know if that's possible. But that's what we're trying to drive to and trying to collect data in a national and international wide database of trying to figure out, can we put things together? And this thing has evolved over the last 20 years because of that. They've collected data. They've tweaked the way they do things. Sara can talk about that a little bit as she gets into each one of these tests. But the home run would be, can we test an athlete and say they have a 25% greater chance than his teammates of suffering an ACL tear? Again, that's a high bar to hit. I don't know if we'll ever get to that point, but that's what we're trying to get to. So with that, I'm going to pass it over to Sara because, quite honestly, Sara's the one that is doing 90% of these in one of our clinics here and sees a lot of our athletes. A lot of them have had surgery, and we're talking, dislocated shoulders, ACL tears, stress fractures in the back, all these things that we see that you guys experience on your teams throughout the whole state of Indiana. So we'll get into the nitty gritty of each test here, and I'll pass it over to Sara for that.
Thanks, Scott. So we have, I'll talk a little bit more about this later, but we have what we consider phase 1 and phase 2 testing. And so the functional movement screen is just a component of another series of tests that we incorporate with regards to returning our athletes to play after injury. And with the functional movement screen, it has a scoring system of a perfect score for each movement pattern is a 3, and then the totality of the score is 21. The goal is not ideally to get a perfect score necessarily, but we want to make sure that they have symmetry, because when we see asymmetry between one side and another, there's increased risk of injury, whether it be in that particular body part that we are seeing them for or in another location. So when you're looking at the deep squat that you see here on the screen, the movement pattern actually tells us a tremendous amount about how the athlete is moving, and each of them in and of themselves do a great job of telling us where to look to find deficiencies. So with this particular individual, when you see the deep squat patterning, you want to make sure that the torso is parallel with the tibia. So if you see his arms extended overhead, he has a deep squat where he's able to get his hips below his knees, and you see a forward shift from that lower leg. We want to see that alignment. And a lot of times post-operative ACLs, they struggle to get below 90 degrees and they struggle to get their knees forward because they either lack ankle mobility or they are constantly shifting. Once they get that injury or they're recovering from the surgery itself, they'll shift to the non-operative side to avoid putting that stress or strain on that particular movement pattern. And so this right off the bat, this is the first one that we look at, and this tells us how well are they recruiting their quads, their glutes, their calf muscles to complete a movement pattern successfully. So the little diagram on the left, it kind of shows you a little bit of a variation of that squat movement pattern and things that we look at to see whether or not they are moving well. And the picture on the right is where we see somebody that has essentially perfect technique. So that one would be scored as a 3. Okay, Scott. The hurdle step, they, interestingly enough, a lot of times patients that come to see us with knee injuries, they don't have the knee flexion on this one. And so they'll knock over the cord and they don't have the core or the upper torso control to maintain alignment of that dowel. So when you look at the dowel that they're holding across their shoulders, we want that to be parallel with the bar. We don't want to see a shift in either their thoracic or their lumbar spine. We want to make sure that they can perform that movement pattern where they hurdle step. So they're taking that right foot over the cord in front of them, touching with their heel, and then returning to the start position. And so we want to see, are they plantar flexing their foot to avoid the cord? Are they externally rotating their hip or rotating their ankle to make that movement happen? Or are they struggling from a core stability or a glute strength ability and they have to shift their hips? There are a lot of things which each of these movement patterns that kind of cue us in on what muscles are weak, where they lack mobility, and things that we need to strengthen. The next. The inline lunge, often we see with patients who don't have eccentric control. So you're looking at the individual on the right where he's touching his right knee to the center of the board. We want that person to be able to maintain an upright torso where the dowel, the bar behind them, is vertical. If they can't maintain that, we know that they either don't have core stability or they're struggling from a muscle or a mechanical standpoint to get that knee to the board. So if someone's able to maintain that position and maintain a vertical dowel with that inline lunge movement pattern, then we would score them as a 3. If they're able to complete the movement pattern, but it doesn't look perfect, it's a 2. And then if they're unable to complete the movement pattern with all of the ones that we are scoring, then it's a 1. If they have pain with any of the movement patterns, then they will receive a 0. And we do that because anybody that has pain with a movement pattern, that's going to change how they function from a motor control standpoint. We don't want pain to elicit an inhibitory response and cause problems elsewhere. So again, the individual that you're seeing on the screen, we want them to be able to touch the knee to the center of the board, and we want them to be able to maintain that upright torso in a vertical manner throughout that movement pattern. And that is very challenging for an athlete who may have had an ankle reconstruction, or they're recovering from an ACL, or they might even have a rotator cuff issue. So again, these are all key things that we can identify when we look at each movement pattern. The shoulder mobility pattern, they receive a score of 3 if their knuckles are within 1 length of their hand. They receive a score of 2 if it's within 1.5, and anything beyond that, it's a score of 1. If they have pain with the shoulder clearing test, then they receive a score of 0. And we compare that from both the right being overhead and the left being overhead. With the active straight leg raise test, that tells us whether or not they are lacking hip mobility, or if they have significantly tight hamstrings that are limiting the control of their pelvis, as well as can they maintain their low back into the floor when they perform that straight leg raise. And we also look at, can the opposite limb maintain contact with the board while the other leg is doing a straight leg raise. That tells us whether or not they have some significant restrictions in their hips, in addition to an inability to stabilize their spine, even in a position where they're lying on the ground. With the trunk stability push-up, this one it varies just a little bit with particularly our soccer players, our primary lower extremity users. You will see oftentimes a lag. So when we have our post-operative ACLs and the first time that they might test, they may have a significant lag in their spine from their upper body whenever they perform the movement pattern. So males have to perform a trunk stability push-up, aligning their thumbs with the middle of their forehead. Females will try it from their chin, and if they can't perform it successfully from their chin, they'll drop to their shoulders. And then if they can't perform the movement pattern at all, it's a 1. So we look at, can they maintain a plank throughout the movement pattern? So when they lift off and elevate, they should have a straight line from both their ankles to their knees to their hips all the way to their shoulders. And it's interesting to see how in the early stages, when they haven't developed some of that core musculature, and they're focusing on getting the range of motion perhaps in our lower extremity and gaining that strength, and the upper extremity can sometimes, or the core can sometimes be forgotten. And so this helps us identify, okay, you need to remember to initiate some of this into your movement patterns. The next one is a rotary stability. I apologize for not having videos for all of these. It was a little slow with our technology, so we opted for pictures. But what you're looking for here, the top screen, you're actually same side to same side. So this is a prior movement screen. And now they've changed it. So the rotary stability is going to be extension of the same side. So it's extension of the right arm, the right leg, and then it will come back and touch their ankle. So they'll touch the outside of their malleolus, or the bone that's in their ankle, and then they'll fully extend, and then they'll return to start position. This is a really challenging movement pattern. It's cross-linking between the upper torso and the lower extremity. And if you have somebody that has developed a glute weakness, for after a post-op or a lower extremity injury, they will struggle to maintain this position, and they often fall over. And the clearing test for this is really eye-opening. A lot of times we're referred patients from outside facilities who might not be doing as well as they should. And one of the things that we identify from the get-go is, do they have enough mobility to even sit on their heels? So the demonstration on the right is a patient that has to sit back fully on their heels, touching their heel to the butt, and then reach out in a child's pose position. And that again helps us identify where some of their mobility restrictions are that are preventing them from being successful in their rehab process. So as I mentioned, the phase 1 testing, the functional movement screen is a conglomerate of all of those things. So we look at not only the functional movement screen, but we assess their lower extremity dynamic balance and strength with the Y balance test. We look at a leg press endurance test. So we want to identify how well they can explode or control a movement pattern with doing a single leg press compared to the opposite side. Because again, we're looking at percentages. How strong are they from a postoperative standpoint from one side compared to the other? Because we know that if there are asymmetries with those, there are increased risks of injury, and not only that post-op ACL side, but the opposite side as well. Then we also take them through plank testing, and we have expectations for those, as well as a single leg hop test. So a lot of the initial testing is looking at both the mobility, then we're looking at the motor control, and then we're assessing their functional patterning. So phase 1 is this essentially that foundation. Can they move well? And then from that, we would test them on phase 2. We want to look at how well are they moving? Not just are they able to complete it, but what does that motor programming look like? If they can't functionally perform it in a good manner, but their percentage is good on the phase 2, that's a different story. Athletes have an incredible ability to compensate and create movement patterns and make them happen, but not necessarily with the right muscle groups and without substitution. So phase 2 testing is where we look at their strength, their power, how fast they are, and that's where we assess agility, jump testing, and we create loaded movement patterns, and we look at how well can they control a movement pattern that requires a neurocognitive demand. So the research that is coming out right now shows a significant difference in an athlete's ability to perform a movement pattern without having a neurocognitive demand that's similar to, say, a soccer player running up a field. They have to understand what is happening ahead of them as well as behind them, and then they have to respond to an unplanned change of direction. So one of the things that we're implementing into our skill development and our agility is requiring athletes to perform a task that makes them add and subtract, recognize colors, and do things that are going to have to challenge them. And it's incredible to look at how an athlete's movement pattern changes when they're distracted. So again, that is part of phase 2. And then the further phases we're identifying the sport specific skills that perhaps they could do better with whenever they're performing those tasks.
Sure. So to kind of wrap this up, again, what we're trying to do is take kind of a global versus a regional approach. We're using a holistic approach to view the full body movement patterns, as opposed to just isolated regional joint motions, looking at hamstring flexibility. So we're kind of putting all together, joint movement, muscle length, and control and stability of all that. I think that's important to apply these things to the athletic things we do every day. We want to identify asymmetries, like Sara alluded to. It's not a perfect score we're looking for. We're looking for symmetry within the body, especially when it comes to the lower body, to make sure that there's no imbalances or compensations. As we all know, the number one, well, we may not all know, but the number one risk factor for predicting an injury is a history of a previous injury. And I think we all have seen that. Many people come back from a knee surgery and they've recovered and they're great, and their second game back, they pull a hamstring on the other side, or they sprained their ankle, or they got somebody, and it's just a cascading of events of injuries that they can't get out of. So we want to look at regional interdependence is the term we use. And so identify impairments that may be seemingly unrelated to the main complaint or the main injury, but are underlying contributors, like the ankle we mentioned earlier that might be affecting someone's shoulder range of motion that we can pick up on the squat movement that Sara talked about. So again, all this stuff is pretty critical from our standpoint as healthcare providers, strength coaches, and regular coaches. So we want to identify the weak links. It may not always be obvious, maybe something unrelated, and we want to address those weak links. And there's a difference between being a weak link and a broken link. And so, like we said, a low tire pressure leads to poor driving. But if the tire's flat, you're not going anywhere. So those are non-negotiable things we need to clear before someone is medically safe to get back into their endeavors or their sports. Again, we're testing in corrective exercise, incorporating movements, not just exercise. We use that term a lot. Movement does not mean motion. All right, you can have normal motion, but that is needed for normal movement, but it doesn't guarantee it. It's the other components that control that movement that is just as important. So motor control, stability, balance, posture, perception, coordination, all these things are taken into account when we're doing this screening. And there you go. Hopefully that kind of gives you guys a little bit of an insight into what we're looking at and what the functional movement screen is. And then we'll turn it over to Scott from here.
That was great. Thank you guys for just a great overview of what that is. I personally think I've got experience in this type of thing now, which is it doesn't just apply to our athletes, it applies to all of us. It applies in our repetitive activities. And, you know, I dealt with a back problem, right? I had a surgery, but it wasn't until I dealt with a problem that I realized maybe where my weaknesses were and the need for these more functional programs and exercises. And that's just, you know, playing with your kids, being a weekend warrior, doing your job. If we are not trained or not aware of proper movement patterns, this can lead to these repetitive injuries, right? And so this is important for everybody, let alone our athletes. Where do you guys see that a functional movement screen fits in just as a blanket statement for high school athletes? Is this something that an athletic trainer should do? Is this something that the docs should maybe be recommending more? What are your thoughts on that?
You know what? It's designed for a wide variety of professions to do it, including personal trainers. I think someone with a medical background is beneficial. because that's what you're trying to do, is not only enhance performance, but also screen for injury risk. The home run would be to capture, preseason, at the pre-participation physical or before a team starts, to kind of get some data of who's doing what. I know there's some high schools that they do every incoming freshman at the start of the football season. And if some kids don't have the basic fundamentals, they're not even allowed to go in the weight room. And if they are to go in the weight room, they're doing squats, they're using a dowel rod or a broomstick before they even give them a bar, before they even load more weight on it. And then they'll retest that person at the end of the year. Maybe every year, their sophomore year, junior, see how as we know with adolescents, there's a lot of other factors. They're just growing like weeds, right? So those type of things impact that stuff. So that would be the home run. And then you've got some information on that individual in case they do get injured, because sometimes that's inevitable. Those are going to rear their head. So then you can figure out where they faltered and what's the asymmetries they've had.
Yeah, I agree with everything you just said. That idea of the performance pyramid, we shouldn't be expecting these kids to excel at a skill unless they have the foundational structure to do it well. And I think we skip those steps, especially as we have become more sport specialized from a young age. We get too focused on the skill part, and we lose focus on the foundational movement patterns. I've got young kids. I go to the ball fields all the time. I go to the basketball field. I go to the volleyball field. It's kind of scary to see some of these kids move. They have no core strength. They have no hip mobility or hip strength. They don't know how to shuffle side to side, but we're mad if they miss a free throw, right? So this is so important, I think, to develop skills and develop healthy athletes. I think it's great. The other part I want to kind of touch on there is the idea that this is wide ranging. This applies to all sports. It applies to all skills. And that's important for anybody that wants to excel in a sport. We know that people don't necessarily become sport specific and become successful in that sport, but our athletes who understand how to move, how to react, how to protect themselves, they can play a bunch of sports and they're often the best at it. What are your thoughts on that?
No, I would agree. That's the whole point of the screen, is to be able to capture a wide variety, not even athletes. We do this with the general population, the baby boomers, workers' comp patients, people that are working in blue collar situations where they got to move, climb, lift, and do things. And so it's the fundamental movements you need to live life, not just to swing a golf club or to be a wrestler, engage another opponent one-on-one. So it's very holistic, like we mentioned earlier, and it's very applicable to life. So we do this not just on athletes, but also on someone who's had a total knee replacement, someone who's had a back surgery, such as yourself, that's no longer in high school, is not playing on the varsity team, but wants to stay active, go snow skiing, work in the yard, that type of thing. One thing I think is interesting, I'll throw this out there. I don't know this for a fact, but I'm going to pull this number out of my head. I would bet 20% of the athletes we deal with in our clinic that we are treating with did not get injured playing their sport. They got injured training to play their sport. Mm-hmm. They got injured running or in the weight room or that kind of thing because they didn't have the foundation. They're trying to put 315 on the bar and go squat when they should be using a broomstick cleaning up their movement pattern. So that's 1 out of 5. That's 20%. That to me is a preventable thing on us as strength coaches and ADs and athletic trainers and stuff like that. Those are things that we need to help those people out and prevent those things from happening.
A little bit along those lines, are there specific functional movement screens that are sport specific, such as a golf Titleist Performance Institute screening? Are there more of those out there?
Yeah, so there's essentially one for every sport that is out there. Everybody has kind of jumped on that bandwagon in terms of making it more sport specific, skill specific, again, because they're trying to give everybody that that inner edge and that advantage to doing that. The functional movement screen, what we love about that one is that it's applicable to all sports. And so that's the main reason that we utilize it, because it helps us identify anything from core issues, to mobility deficits to flexibility deficits. So that is, again, another reason we use it across the board, because it looks at the totality of the patient or the athlete and not just one specific part of that sport.
Great. Yeah. Applicable to all the athletes coming around.
Mm-hmm.
Are all certified athletic trainers coming out of their programs familiar with this?
I would say most of their clinical education programs, are implementing this as part of their evaluation process. Yeah.
Right. And from your guys' experience, what is the most common deficiency you see for people going through the screening?
I would say glute weakness is a big one. Ankle mobility restrictions and core weakness as well. From a lower extremity standpoint, we see a lot of thing that transcends from somebody who may have come in with an ankle injury or a hip injury. And a lot of times the reality is they needed to be looking at the joint above or below whatever joint it was that they were in for, because the likelihood is that they lacked mobility in the ankle or strength in the hip, and then that contributed to them suffering that injury. So, yeah.
Could you talk a little bit about the idea of proximal to distal thinking? Meaning, do we feel that core stability and proximal joint range of motion strengthening can prevent distal injuries such as knee and foot or ankle?
Absolutely. I think it goes both ways. If there's a weakness in the ankle, I think that contribute that, or there's a mobility restriction in the ankle that can contribute to like an ACL injury. If they don't have the ability to dorsiflex the ankle, that shifts that shear force to the knee. So there's absolutely both proximal and distal thinking to that regard, for sure.
Okay. Is there a recommended age to start this type of screening? My daughter's 9, and sometimes I just cringe watching her try to change direction, and I'm just waiting for that ACL tear, and I'm waiting for the patellofemoral dislocation, and her hamstrings are tight, right? And her glutes are so weak, and she's growing like a weed, and all the girls that age are like that. And now I've got her doing exercises in the morning just to, work on the core strength a little bit. Is there a recommendation for age screening?
Anybody that's active, the reality is they should have a baseline and know where they're at. So there isn't a certain specific age that we recommend to, but if they're playing a sport and they're expected to perform, 3 to 5 days a week, then I would recommend it.
Great. This was awesome. I really appreciate your time and effort putting a presentation together. I really hope everybody got some good information from this. I know I did. I did have a question from the audience. They were wondering if an athlete can get a functional screen at Forté without a doctor's order or being treated for an injury.
Yes, they can.
So just call our scheduling department. We can set it up.
Easy enough.
Yep.
Once again, thank you everybody for spending some time in your busy day to join us and be a part of the webinar. Again, we'll send an invite out shortly for our next webinar in January, which will be strength and conditioning. And again, please, if you can, fill out the evaluation, even if it only takes a couple of minutes to give us some feedback. So hope all is well. Have great holidays. Thank you.
Thank you.
Thank you.